Hello and welcome to the Feeling Good podcast. I am your host, Fabrice, and joining me here in the Murrieta studios is Dr. David Burns. Hi, David.
Hi, Fabrice.
Dr. David Burns has been a pioneer in the development of cognitive therapy, and he is the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 20 languages. He is an emeritus adjunct clinical professor of psychiatry at the Stanford University School of Medicine. This is episode 44 of the Feeling Good podcast. We're going to continue the previous one and talk some more about the hidden emotion technique used with obsessive compulsive disorder. Before we do that, David, let's make an announcement for a couple of workshop intensives you have coming up.
Yeah, on July 17th through 20th, 2017, I'll be teaching in Banff, Canada. That's a 4-day intensive on the treatment of depression and anxiety. For more information, you can call 1-800-456-5424 or go to my website workshop page at feelinggood.com.
Yeah.
And there you'll find the links to the brochure and the registration and so forth. Mm-hmm. The second summer intensive, 4-day intensive, will be in Burlingame, California from July 31st to August 3rd. This one is a tremendous one because of the evening sessions, extra live demonstrations with volunteers from the audience, and lots of opportunities for the participants to practice. There will be a lot of people there from my Tuesday group at Stanford helping out with the small group practice. And if you're interested in that one, you can call 1-800-258-8411, or again, go to my workshop page at feelinggood.com, and if you scroll down there, you'll find a link to the brochure for this summer intensive from July 31st to August 3rd as well.
And I want to add about this particular intensive, because it's located here in the Bay Area, you get to have some tremendous helpers who are coming from your Tuesday group, and those are like level 4 trainers, people who also work at the Feeling Good Institute. So you have a tremendous crew helping you there.
Yeah, it's a joyous event, and it's the best teaching of the year usually.
Yeah. So let's kind of resume on examples of using the hidden emotion technique with OCD. You had a couple more vignettes to tell us about.
Oh, yeah. But the thing I want to emphasize, and we were talking about earlier, is that this isn't a single miracle cure treatment for
not
OCD. The hidden emotion technique is one of 40 techniques or 50 techniques I use with OCD patients.
Right.
It just happens to be one that most people haven't heard of, and one that has tremendous healing potential, and it's great to know about it. And if you have any form of anxiety, whether you have a phobia, whether you have post-traumatic stress disorder, generalized anxiety, worrying constantly, performance anxiety, social anxiety, panic attacks, the hidden emotion technique is something that could be extremely helpful, even curative for you.
Yeah, it bears repeating that, we're talking about technique this and technique that, but really it's about the team CBT model. The
Yes.
entire model is what makes things work.
Right.
It's not, one specific technique.
Yeah, you don't just throw a technique at a patient based on a diagnosis, although most people in the field do that.
Yeah.
And then should we also say, before I give these vignettes and more practice, because I think you'll find this technique is really heartwarming and arguably mind-boggling. The way you do it, whether you're a patient or an individual, is you find yourself worrying or having panic attacks.
Yeah.
And you get to thinking about the symptoms and what you're going to do to control the symptoms or eliminate the symptoms. You get involved in what's called treatment. But a good technique to think about, among many other techniques that can be helpful, is the hidden emotion technique. And the way you do it is you ask yourself the question: Is there something that's bugging me, that's been bothering me in my life just recently? Something in the here and now, in the last few days, that's upsetting me, that I'm kind of sweeping under the carpet, that I'm not attending to. It could be somebody that you're angry with, something that you're upset about, some feeling that you have, even a desire that you think you're not supposed to have, or a tender emotion, like in the last podcast, just a medical student who thought he wasn't allowed to feel sad and lonely and vulnerable, and so he would suppress those feelings, and then suddenly he had OCD symptoms. But it can be any kind of anxiety disorder you get when you're suppressing feelings. And there's two parts to this technique. One is called the detective work, and that's the hard part, both for therapists and for the patient. And that's kind of figuring out what's bugging you. And I'll give examples that will make it seem easy and obvious. Yeah,
because many people don't have a lot of insight into what's going on inside of them.
Yeah.
Haven't you had the experience of asking a patient, how do you feel? And they tell you how they think instead.
Yeah. And just some of us are just programmed that we don't notice when we're upset with somebody or upset about something, because we think, I'm not supposed to feel that way. So
I'm fine.
Yeah, but just help me with my airplane phobia or my panic attacks or my OCD. So let's do some. So the first thing is figuring out what is bugging you that you're repressing or suppressing. That's the hard part. In my experience, the easier part is once you figure out what you're avoiding, the feeling or the conflict, then expressing those feelings or doing something about it, that's where you get the relief. Now, I'll give you some more some vignettes here so you can see if you can develop some skill here at the hidden emotion technique.
Yep.
And again, I always disguise these vignettes, but I treated a doctor with OCD. He was a very nice guy. He was working as a family practice doctor, which isn't one of your more lucrative medical specialties, and he was working with people in kind of poor neighborhoods, but his clients didn't have a lot of money, and he was taking Medicaid and Medicare and kind of insurance payments that were very, very modest or even meager, and he was giving people a lot of extra time because he wanted to talk to people, not just get them in and out of the office. So he was working about 60 hours a week, and but just a really nice guy. And then he was married, and he and his wife had a baby, and then he came to me for treatment because they lived in a small apartment.
Yeah.
And it was a second floor apartment, and so when he'd be walking with his baby, he had the idea that he was going to throw her over the railing. And this was, terrifying him. Yeah. And this is typical OCD, and this is not somebody who's prone to violence. He's not actually going to throw his baby daughter over the railing. He's not going to kill her. He doesn't want to kill her, but he has this fear that this is going to happen. And so now my question to our listeners is, what is the hidden emotion that he's not admitting?
Okay, should we ask people to pause right here?
Yeah.
Okay. So let's have the answer.
Well, did you come up with an answer, Fabrice?
Well, for me, I would say that, he was working a lot and feeling like maybe he wouldn't be able to see his daughter as much because he's working a lot. So something related to his family and his work, the lack of balance between the two.
Exactly. Now, how does somebody feel who's giving, and getting nothing or little in return, and then on top of the 60 to 70 hours a week has now a baby who poops and cries?
So, of course, he could be feeling resentful, which is not acceptable.
Exactly, because he's what kind of person?
He's a nice person, of course.
So that's the hidden emotion. And once this came to conscious awareness, then he took some steps to modify the way he was doing his practice, modify his life, and not be in this kind of victim role to express those feelings and move forward with them. Now, I'll give you another example here. And again, I'm making it seem easy.
But how did that get uncovered? What was the process to get to that?
Well, what I do is I just say to the person, see, when I present the vignette here, we've already figured it out.
Yeah.
But usually it takes 3 or 4 or 5 sessions for us to figure it out. And what I say to the patient, and if you're a therapist, the way I do it, I just say to the patient twice a session. See, usually I'm using other techniques, cognitive techniques, exposure techniques, motivational techniques. But twice a session, I will say to the patient, and we'll be making partial progress, but generally not a complete elimination of symptoms. And then I'll be saying to the patient, I think there's something that you're not telling me that's bugging you. And I'll sometimes make an interpretation, just say, like, you feel like you're going to throw the baby over the railing. Do you have maybe some negative feelings about the baby or something like that? Mm-hmm. And then a patient will say, oh, no, I love the baby and I would never want to kill her. And say, what you're saying, doctor, doesn't make any sense. And the patient will shoot me down. And then at the end of the session, I'll ask the same question again. Is there something bugging you that you're not telling me? Could it be this? Or are you having a conflict with your wife? Or maybe you're concerned this isn't your baby. Or maybe you're concerned she had an affair. And then they'll say, oh, no, that doesn't make sense. And usually,
so you're offering different choices.
Yeah, just to get them thinking about it. And I usually get shot down. I don't expect to come up with it. And then generally after 2 or 3 sessions of getting shot down, and again, there's just 1 minute twice a session is all I spend on it. And then generally the patient will say, I've been thinking about that, and this thing just suddenly dawned on me that I forgot to tell you. And then the patient will generally come up with that, and then the detective work is done. You say, obvious, that's obvious. Right. And then I encourage them to act on that, to express the feelings, to solve the problem. And to be honest, I haven't had problems that had patients who had trouble with that. They always seem to take appropriate action, express the feelings. The problem is figuring out what it is, because it's like it's suppressed in the subconscious somewhere. The patient kind of knows, but the patient doesn't. They don't know that they know. It's the part of me that's talking to you right now is the left part of my brain here.
Yeah, and only a small part of that.
Yeah, the Broca's area where the speech is generated. Yeah. And it's almost as if, let's say, I was mad at somebody, and the right half of my brain knows that.
Yeah, but can't talk.
Yeah, it can't talk. So it's got to spread the message over the corpus callosum to the left half of the brain. Yeah. So if you were to ask me, David, are you upset about something? I would say, no, I'm not aware of anything. Right. Because the part that's talking to you, the part of the brain, isn't connecting to that other part.
Meanwhile, the right brain is going, but yes, you are.
Exactly.
Just tell him.
Exactly. And so I try to activate that part of the brain by saying, I wonder if it's this. I wonder if it's that. And eventually the message, they shoot you down, but it gets activated, and then the message shoots over the corpus callosum. Yeah. This is metaphorical. I'm not saying this is neurologically correct.
No, I get it. Yeah.
And then suddenly the speech area knows what it is, and then can take action on it. Yeah. But it's really a neat model because it has this amazing healing potential, and also because, although the psychoanalysts kind of were onto this type of thinking, very few of the modern cognitive therapists or behavior therapists, exposure therapists, they're not aware of this model, and so they're kind of handicapped, although the tools they're using are good and have helpful healing aspects. Often you can't get the complete elimination of symptoms until you bring in this dimension. Let's take another example here for our listeners. And a woman came to me with a hand washing compulsion. By the way, we may be able to do another live therapy soon. We have a volunteer with a hand-washing compulsion, contamination phobia.
Oh, that'd be good.
And if we can get the recording devices to record, we'll have to take her out in public and, expose herself to contamination. So we have to be able to see if we can record that, but it could be cool.
I want to say, by the way, the live session with Mark has received a lot of great comments. So this is encouraging us to
and in the Tuesday
do more
group,
live sessions.
He said a number of his friends had heard it.
Yeah.
And he said they were just over the top with admiration and praise. Yeah. It's so interesting when people do live podcasts, then or a live thing in a conference, they're generally afraid people are going to judge me.
Yeah.
And then it has the opposite effect, and people admire them and appreciate them so much for their vulnerability and openness, just like the young man we talked about in the last podcast who had this sweating compulsion or fear or phobia or whatever. Well, this woman came to me. She was from Los Angeles, let's say, and she was washing her hands 50 times a day. She had OCD, and she was also in her home afraid to arrange anything in threes.
Yeah.
So, like, there could be 2 magazines or 2 candles, but not a third.
Not a third one. Yeah.
Yeah, but 4 is okay. 5 is okay. Yeah. But we're not allowed to have anything in 3. So she would spend tremendous amounts of time studying her house and from different angles and the arrangements and make sure nothing's arranged in 3s. And she was washing her hands 50 or 60 times a day or 70 times a day, and her hands were just all red and chapped.
Yeah.
And she wanted help with this OCD. Now I did with her again the what if technique. What are you so afraid of if you didn't wash your hands? And she said, well, then they'd get contaminated. Okay, and then what would happen? Well, then I would touch my children. And then what if that happened? What are you the most afraid of? She said, well, then they'll get contaminated. And then my question was, and then what are you the most afraid of? What would happen then? What are you the most afraid of? Oh, then they'll die of leukemia. So again, here is this what-if technique that we went over in a recent podcast, and this is her core fear in terms of the hand-washing compulsion. So now we'll ask our listeners to pause and turn off the recording and write down your hypothesis. And it isn't important that you get it right. It's okay you get it wrong. I get it wrong almost 100% of the time. But it's important to come up with some kind of hypothesis when you're working with a patient or working with yourself. So you begin to ask yourself, what is this very nice woman, what is the feeling that she's sweeping under the rug?
Okay, so let's get the
answer. Are we back now?
We're back, yeah.
Okay, great.
People can pause, but we can't really leave dead air on the podcast.
Yeah, okay. So we hope you listeners did that and came up with something. Did you have any hypotheses, Fabrice?
Well, of course, we don't. I don't know the whole story, but there could be a hidden emotion there in terms of maybe her children could be a burden on her, and of course, that's not acceptable to look at your children that way.
That's a really good thought, and this one is somewhat obvious. She was a very nice woman, a psychologist actually, but children act out quite a bit.
Really?
Even we have a little kitty who's now starting to do that. We love her to death, but it's just a part of our genes, our human nature, cat nature. And she would get upset with them, and she would try to discipline them with logic and love. Yeah. Do you think that's going to work?
Well, Sometimes can, but
do you think it's working in this case?
No, I don't think so.
Right. So what's the name of the emotion that she has toward her children?
Anger.
Anger. So you see, she's afraid her hands are going to kill her children.
Yeah.
Do you see that?
Yeah.
And that was the thing. She was really, angry with them, but she was just exceptionally nice, and she was really a neat lady, but she had trouble admitting that to herself, and she's sweeping it under the rug, under the carpet, and then it comes out indirectly as this obsession. And so we had some sessions on how to deal with her children in a little bit more tough love, a little bit more structure, a little bit more limit setting there. It was extremely helpful to her. Now, let's look at her other problem. This may be harder for people to figure out because there's fewer hints, but why is she so afraid of having anything in her house arranged in threes? Because this is another typical OCD thing. People are counting things or checking the stove, the burners all the time. Did I leave the burners on at night? And they check them. Did I forget to lock the door? And they check the door over and over again. And in this case, she's all obsessed with making sure that nothing in her house is arranged in threes.
Well, I doubt that the number 3 has anything to do with it.
But before you come up with something brilliant, let's tell our readers listeners to turn off and just
make a pause and think about this and jot down some hypotheses.
Yeah. Okay, we're back.
All right.
Do you have any hypothesis, or maybe you've heard it, the vignette? I don't know.
No, it doesn't ring a bell. But this is about making sure that things don't fall apart, that we stay in control. So it's about staying in control.
Mm-hmm.
And
that's true.
I don't know. There's not one that comes up for now, and I don't want to slow down the podcast. So what do you have to say about this?
This is about the time that I was developing my relationship satisfaction scale and adding it to the brief mood survey at the beginning and end of sessions.
Yeah.
And I suddenly noticed she had a very low marital satisfaction scale.
Yeah.
Does that give us any hints?
Yes, and apparently not being happy in her marriage was not acceptable.
Well, right, and her fear was if she had anything arranged in threes, then she would have an affair.
Oh, really?
3. Did you see?
Oh, yeah.
And so what would be then the therapeutic intervention?
Have an affair. No, just kidding.
She loved her husband, but again, she wasn't expressing her feelings,
yeah.
and he loved her, but they weren't dealing with real feelings. So I brought him in and did some couples work.
Yeah,
and they
talk to each other.
Yeah, began to talk to each other. Then suddenly the OCD disappears. Yeah. So that again is another example of the hidden emotion model. Now those are easy examples. I could give a really tough one, or perhaps there's enough examples at this point.
Okay. So do you have any recommendation for clinicians who want to put that into practice? Any pitfalls, perhaps? Because what you described was rather simple, asking just a couple of times a session, is there something that you haven't told me yet, or is there something that you don't want to talk about, and
throwing out some hypotheses.
Throwing out some hypotheses.
Well, I would say you don't want to do it in an accusational way, and you don't want to try to read things into your patient or tell them how they're feeling, because in my experience, 99% of the time, I'm wrong in my hypotheses. The only purpose of the hypothesis is just to get them thinking about this. But also, if the patient says, your hypothesis is incorrect, then your hypothesis is incorrect. Don't try to force that on the patient, and let them kind of come up with it. And then the other thing, again, if I'm not working with one technique with the patient. I'm working with a recovery circle, a daily mood log, and taking one of their negative thoughts and putting it in a recovery circle and selecting 15 to 20 techniques from my list of 40 techniques. And they'll fall into 4 categories: cognitive techniques, exposure techniques, motivational techniques and the hidden emotion technique. So this is just one technique, among many that I would be using with any anxiety disorder. But I would say 80% of the time I've seen this phenomenon in my anxious patients, no matter what type of anxiety it is, that it seems to be fairly common.
Okay.
And I've also, one other thing I would say, when clinicians first hear this, they don't believe it. They are skeptical that this hidden emotion thing could be going on. I've had very few clinicians who initially believed what I was saying. And it's hard, too, because the patient will be so good at convincing you there's no problem, just help me with my OCD, my panic attacks, my phobia.
Yeah.
But you really have to kind of keep the faith and persist in it a little bit, because it suddenly emerges after many denials on the part of the patient. Should we take I don't know how we are on time. I could give a real difficult example, a more challenging.
We have a few minutes left. I have a question for you, though. Some people have, OCD or phobias that seem to be traceable to one specific event. Like when this happened to me, like I had a car accident, and then from that day on, boom, my symptoms appeared.
Sorry.
My symptoms appeared, and so then they would say, and see, it's because of my car accident. It's not because of something else. What would you respond to that?
Well, we could have a podcast on that topic, if you like, because I got a wonderful vignette. In one of my recent trauma workshops, a woman volunteered for the live demonstration, and she'd had 3 horrific auto accidents in about 2 years, 3 rear end accidents, and each of them, her car was demolished, and 2 of them went flying through the air, and she had a lot of emotional consequences in terms not only intense physical pain, but intense anger, intense depression, intense anxiety. And we could talk about the treatment of her, but to make a long story short, it was Team CBT. It was working systematically with the model, first empathy, and then agenda setting, and then the daily mood log, recovery circle, and what the techniques were. But it was a fantastic case, and we could even include some PowerPoints and vignettes showing her her daily mood log. But I used many techniques, and the outcome of it was really fantastic.
Okay, great.
Inspiring. I call her Lily, so remind me to
okay, Lily. We'll make a note of that, Lily. So, to conclude, I would like to remind our listeners that we very much appreciate their comments on the show notes, to go to the feelinggood.com website and leave questions, comments. We like to hear some feedback and what people want to hear about that's more specific. And of course, we encourage everyone to subscribe to the podcast. If they're not subscribed, if this is like a one-off that you're listening to, please click the subscribe button. And there's a button also at the bottom of each show note that will point you to leave a review. So you can do this on iTunes. And talk about it in your Facebook post and your emails to your friend, and let people know that you enjoy this podcast.
Yeah, help us get support for the podcast and also for my blogs on feelinggood.com, because I'm trying to learn about social media. I don't know much about it yet, but we're trying to increase the subscribers and increase the awareness. And so if you have individuals who have an interest in psychological themes because of their own OCD, their own suffering, or if you're a therapist, many therapists I know are now requiring their patients to listen to at least 3 Feeling Good podcasts before they'll even accept them as a patient.
Yeah.
And they say it just really facilitates recovery. So we'd love to get as many people as possible aware of what we're doing.
Yeah. So thank you, David. We'll see you next time.
Okay.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes for this podcast under the blog page, and where you can leave your comments and questions. The website has an abundance of resources for therapists as well as non-therapists, including books, workshops, a list of online training groups around the world, and much more. theme music is Gypsy Jazz in Paris, 1935, composed and performed by Brett Van Donsel. I am your host, Fabrice Nye, and I invite you to join us next time for another episode of the Feeling Good podcast.